Hi everyone, my presentation is on shoulder dystocia. So shoulder dystocia is a birth injury that happens when one or both of the baby's shoulders get stuck inside the mother's pelvis during labor. So risk factors. If the mom has previously had an assisted delivery, meaning that the previous delivery was either with forceps or a vacuum, this is a good indicator that she's previously had bigger babies that did not fit well and she needed some type of assistance to get the baby out. If the mom is overweight, macrosomia, or that just means it's a fancy word for a big baby, meaning the baby weighs more than 8 pounds 13 ounces at birth. Pre-existing diabetes or gestational diabetes. So if the mom is already a diabetic or she acquired diabetes during pregnancy, these mothers typically have bigger babies at baseline. So if you see that the mom has gestational diabetes, then you're already thinking that there might be a risk for a shoulder, history of a previous shoulder. So likely if the mom had it the first time, she will likely have it again the second time. Or multiple gestation, meaning that there's multiple babies, twins or triplets. If your patient has any of these, to prepare, you should have like a stool in the room that's so that you can stand up higher than the bed for some of the maneuvers. You should, some providers like to break the bed, meaning that the bottom of the bed comes off. It just allows for them to get closer and be able to like do more of the maneuvers easier. So problems that arise if you do have a shoulder. So a fracture to the collarbone and arm. Sometimes this is done intentionally in the maneuvers, and sometimes it's done accidentally in an effort to get the baby out. Damage to the brachial plexus nerve. This is the nerve that goes from the spinal cord in the neck down to the arm. It provides feeling and movement in the shoulder, arm, and hand. So a sign that there might be this nerve damage is when the baby is out, the baby may not be moving the arm that was directly related to the shoulder. They'll have weakness. Typically, if just a normal vaginal delivery, a baby's going to come out and be moving both of their arms around. If you notice that one arm isn't moving as much, then this is a good time to have NICU or the pediatrician evaluate the baby. Brain injury, this is the more serious and not very common, but it is possible. So lack of oxygen, meaning the baby's head is out and it's taken multiple minutes to get the baby the rest of the way out. So lack of oxygen to the baby has created a brain injury, and this could also result in death, but once again, this is very rare. And then problems that occur for the mom are postpartum hemorrhage. It's just heavy bleeding after delivery, and that's just because the body's been stressed getting that in that last phase of labor, getting the baby out. So treatments. So typically scheduled C-section for suspected is very rare. Typically you see this for the people that have had a history of a shoulder. If it was a very bad shoulder the first go around and mom gets pregnant again, some OB attendings will just ask the mom if she will consent to a scheduled C-section from here on out, just for the safety of her and the baby. Induction at 39 weeks. If they are thinking that the baby is going to be big, they might opt for doing a C-section at 39 weeks to hopefully prevent further growth. If mom has gestational diabetes, they can do an induction a few weeks sooner depending on how her diabetes is, if it's controlled or uncontrolled. But the main thing with shoulder dystocia is that it's not usually expected. We always prepare for it, but you don't usually know when it's going to happen, so it's better just to be prepared. So the next is maneuvers. So starting over here on this side with McRoberts and working your way around. So McRoberts is just when you bring the mom's legs back very far. So there'll typically be an assist on both sides, taking the mom's legs and pushing them as far back as you can. It's hyperflexion and abduction of the hips. It's just hopefully creating more of an opening in the pelvis for the baby to come out. Suprapubic pressure is exactly what it sounds like. You're applying pressure on the pubic area. The OB attending should be able to feel for where the anterior shoulder is, and then that is where they would ask somebody to apply the pressure. Wood screw is an attempt to rotate the posterior shoulder counterclockwise by applying pressure on the anterior surface of the posterior shoulder to try and rotate towards the fetal back. So it's exactly how it's on screw. You're just trying to twist the baby and see if you can free up a shoulder to deliver. Rubin's maneuver is applying pressure on the posterior surface of the posterior shoulder to facilitate shoulder rotation around the fetal chest, allowing for delivery of the posterior arm. So you want to deliver the lower arm in the pelvis. Posterior arm delivery, so an attempt to deliver the posterior arm by sweeping across the fetal chest and bringing it out of the vagina. So the provider will reach in and try and grab onto that little arm and pull it out. Gaskins is also known as the all fours maneuver, hands and knees. You try and get mom into this maneuver. This one's very hard, especially if she does have an epidural, because the lack of movement. So this maneuver is not always an option considering if the mom has an epidural or not. The clavicle fracture. So this would be if the provider was intentionally doing this, so they'd be applying pressure to the baby's clavicle, breaking it, just in order to shorten the diameter and hopefully get the baby out. And then Zavanelli is a rescue procedure, and this is when you push the baby back into the vagina from the head, and you're going to go back for a C-section. So that is worst case scenario. You hope to never get to that point. The other thing to remember with all of the maneuvers is McRoberts and suprapubic pressure are typically always done first. They're the easiest ones to do, and they have great success. If they do not work, any of the other maneuvers like wood screw, Rubens, posterior arm delivery, Gaskins, all of those can be done in any particular order and repeated as many times as the OB provider feels necessary. So they might go through all of them and then try again, depending on how the time is looking, before they proceed with the fracture or trying to go back for a C-section. So then post-delivery, it's important to talk to the mom and educate her when the timing is right on the risk of recurrence. Typically, the OB provider is going to do this, but it's good for the nurse to have some education on it as well, because the mom's likely going to be asking about it, especially if this is their first baby. So it's important just to let them know that if you've had one shoulder, it is likely that it'll happen again, but it'll be a bigger discussion come time if she gets pregnant again. Status of the infant. Likely if you've had a shoulder, NICU is going to be there, or you've called for NICU. So hopefully they would be able to give the mom the update on the infant, letting her know if there was any fractures or anything to be mindful of, or how the baby was doing, if they had that loss of oxygen, are they going to the NICU, what to look for. And that goes along with injuries to mom and the baby. So sometimes in these maneuvers, the providers will also do an episiotomy, so it's good to let the mom know if she has a bigger tear than usual and kind of what her recovery process looks like from that, or if she did end up with a C-section, going over the care that she'll need for that with the thought that she made it all the way to almost delivery and then had to go back to C-section, so care for both her vagina and the C-section incision. And then just being available for questions. So this experience is a lot for the mom, you know, it can be very traumatic. So just being a good support person and being able to answer the questions that she has, or being able to get the provider or the NICU providers to help clarify any of her concerns.